Hello everyone, this is part 2 of the history and examination of the psychiatric patient. This talks of the mental state examination. So mental state examination is analogous to performing a physical exam in other areas of medicine. It is the nuts and bolts of the psychiatric exam. It should describe the patient in as much detail as possible. The mental state exam assesses the following: appearance, behavior, speech, mood, affect, thought process, thought content, perceptual disturbances, cognition, insight, judgment, and impulse control. The mental state exam tells only about the mental status at the moment. It can change every hour or every day. So, for example, you collect a patient today and then you have a specific mental state. Then the following day, you might get a completely opposite picture. So, that does not mean that the mental state of the person that clicked XYZ was wrong. It means that at that time, that's how the patient was presenting, and this time it's different. So, mental state exam changes very quickly. It can change every hour, every day, or even in a few minutes. So, you need to take note of that. Mental state examination. So let's start with appearance behavior. So when we talk about appearance and behavior, we talk about the physical appearance, gender, age, do they look older or younger than stated age, type of clothing, hygiene, including smelling of alcohol, urine, feces, posture, grooming, physical abnormalities, tattoos, body piercings. Take specific note of the following, which may be clues for possible diagnosis, such as pupil size. That's going to give you an idea on drug intoxication or withdrawal. Opioid intoxication leads to wet pinpoint pupils, right? Bruises in hidden areas, that's going to increase the suspicion for abuse. Needle marks or tracks would point towards drug use. Eroding of tooth enamel, that may be due to eating disorders from vomiting. Superficial cuts on arm, that's self-harm. Behavior and psychomotor activities, we talk about the attitude, the cooperative, seductive, flattering, charming, eager to please, entitled, controlling, uncooperative, hostile, guarded, critical, antagonistic, childish, manneristic, eye contact, activity level, psychomotor retardation, activation, akathisia, automatisms, catatonia, choreoathetoid movements, compulsions, dystonias, tremors. So you put in the positive findings. You don't need to include all the negative. This was not present, that was not present. Just include the positive findings. Speech. So speech when we talk about the rate, which can be pressured, slowed, or regular. The rhythm, which may be prosody. Articulation is steady, aria, or stuttering. Is the accent, dialect, volume, modulation is loudness or softness, tone, long or short latency of speech. Then the mood is the emotion that the patient tells you he feels, often in quotation. So under mood, the different literature seems under mood there is subjective and objective. So subjective is how the patient feels their mood is, so that has to be in patient's own words. And objective is how we feel the patient's mood is. So what's affect? Affect is an assessment of how the patient's mood appears to the examiner, including the amount and range of emotional expression. It is described with the following dimensions. Type of affect can be euthymic, euphoric, neutral, dysphoric. Quality and range describes the depth and range of the feelings shown. The parameters are flat, none, blunted, shallow, constricted, limited, full, average, intense, more than normal. Motility describes how quickly a person appears to shift emotional states, such as sluggish, supple, labile. Appropriateness to content describes whether the affect is congruent with the subject of conversation or stated mood. Parameters are appropriate or not appropriate. Thought process. The patient's form of thinking, how he or she uses language and puts ideas together. It describes whether the patient's thoughts are logical, meaningful, and goal directed. It does not comment on what the patient thinks, only how the patient expresses his or her thoughts. So circumstantiality is important in thought process. So this is when the point of the conversation is eventually reached out, but with over inclusion of trivial or irrelevant details. For example of this is beating around the bush. You do get to the end, however you have a lot of irrelevant details. So examples of thought disorders include tangentiality. Point of conversation is never reached. Responses are usually in the ballpark. Loosening of association. There is no logical connection from one thought to another. Flight of ideas. Thoughts change abruptly from one idea to another, usually accompanied by rapid pressured speech. Neologisms. Made up word salad, incoherent collection of words, clang associations, word connections due to phonetics rather than actual meaning, such as my car is red, I've been in bed, it hurts my head. Thought blocking, abrupt cessation of communication before the idea is finished. So what is thought content? Thought content describes the types of ideas expressed by the patient. Example of these resources are poverty of thought versus overabundance, too few versus too many ideas expressed. Delusions, fixed false beliefs that are not shared by the person's culture and cannot be changed by reasoning. Delusions are classified as bizarre, impossible to be true, or non-bizarre, at least possible. Talk about suicidal and homicidal ideation. Ask if the patient feels like harming him or herself. Identify if the plan is well formulated. Ask if the patient has an intent. If released right now, would he go and kill himself or harm others? Ask if the patient has means to kill himself, such as firearms in the house, multiple prescription bottles. And once they tell that they have an idea, then you need to be very aware of such people because they might commit it anytime. Phobias, persistent or irrational fears, obsessions, repetitive intrusive thoughts, compulsions, repetitive behaviors usually linked with obsessive thoughts. Talking about perceptual disturbances. So these include hallucinations, sensory perceptions that occur in the absence of an actual stimulus. Describe the sensory modalities such as auditory, most common visual taste, olfactory or tactile. They need to describe the details. Auditory hallucinations may be ringing, humming, whispers, or voices speaking clear words. Common auditory hallucinations are voices that instruct the patient to do something. Ask if the hallucination is experienced only before falling asleep. That's going to be hypnagogic hallucination, or upon awakening, hypnopompic hallucination. So, just before falling asleep, hypnagogic, upon awakening, hypnopompic. Illusions, inaccurate perception of existing sensory stimuli, such as wall appears as if it's moving, derealization or depersonalization, the experience of feeling detached from one's surroundings or mental processes. About sensorium and cognition. Sensorium and cognition are assessed in the following ways: consciousness, patient's level of awareness, possible range includes alert, drowsy, lethargic, gibberish, comatose. Orientation to person, place, and time, calculation, ability to add and subtract, then memory, immediate registration, dependent on attention, concentration, and can be tested by asking a patient to repeat several digits or words. Recent short-term memory, events within the past few minutes, hours, or days, then remote memory, long-term memory. Fund of knowledge, level of knowledge in the context of the patient's culture and education. Who is the president? Who was Picasso? Attention or concentration, ability to subtract serial 7s from 100 or to spell word backwards. Reading, writing, simple sentences, what makes sure the patient is literate first. Abstract concepts, ability to explain similarities between objects and understand the meaning of simple proverbs. So let's go to insight. Insight is the patient's level of awareness and understanding of his or her problem. Problem with insight include complete denial of illness or blaming it on someone else. Insight can be described as full, partial, or limited or none. So under insight, there are two classifications. There's one that talks about full, partial, or none. Then there's another one which classifies insight into 6 levels. Well, though clinically, the one that is full, partial, and none is the one that's mostly used. If you're interested in knowing the other one, you can let me know. I can add it in the comments or in another video. Judgment. Judgment is the patient's ability to understand the outcome of his or her actions and use this awareness in decision making, best determined from information from the history of presenting and recent behavior, how a patient was brought to treatment or medication compliance. Judgment can be described as excellent, good, fair, or poor. Thank you.